informed physical therapy. As definition uses importance, why are we using this approach? Why do we actually need to apply? Why is it important in healthcare system? So we'll start by the definition. What's psychologically informed physical therapy? Well, it's based on the biopsychosocial model of pain that developed by George Engel. It reinforces the multidimensional pain experience instead of the traditional biomedical model. The traditional biomedical model actually focuses only on the actual pathology, but the multidimensional pain model focuses on or the biopsychosocial model focuses more on the other aspects of pain. So there is the damage and the pathology, and there is the psychological aspect, and there is the emotional aspect, and there is the behavioral and social aspect and cognitive aspect. It has many aspects. Okay, so then it's mostly used for patients with chronic musculoskeletal pain. It doesn't have to be musculoskeletal, it could be any other type of chronic pain. Things like chronic low back pain, fibromyalgia, arthritis, tenomandibular disorders, even cancer, and chronic neck pain. It gives an opportunity to improve outcomes through appropriate consideration of psychosocial factors, developing intervention that distinguish between modifiable and non-modifiable psychological factors. We want to establish a treatment program that makes the patient more able to manage his symptoms, his flare-ups. We may not be able to modify everything, all the factors, so we defined modifiable factors that we can actually modify and establish, and that's what we work on. Then, it doesn't advocate complete discard of biomedical approach. We don't neglect the biomedical approach. If we see a red flag, we say, yeah, that's biomedical, that's an urgent case. But other than this, some people have the psychogenic pain, chronic pain. Pain is not always associated with tissue damage. There is no link between the extent and the intensity of pain and the actual tissue damage. Then, by incorporating cognitive behavioral therapy and acceptance and commitment therapy, beside other interventions that focuses on cognitive and behavioral aspects of pain, along with the emotional factors, along actually with treating the main pathology too, that contribute in pain perception to improve outcomes and manage the chronic pain, hence cessation of patients' suffering, and establishing healthy coping skills, healthy lifestyle that enable that patient to manage their pain effectively. So then we have the aims. As I said, we want to manage, not cure that pain, and that's something the patient must be aware of. We cannot actually cure the pain. Your pain cannot go from 10 to 0 overnight. That's a bit disappointing for some patients, but yeah, that's the real fact. So we got to be realistic. We don't want the patient to feel no pain or to cure the pain. We actually want it to manage it and deal with it. To be able to continue your life and to live your life, even though in your lifestyle happily, even though you have that pain. Then we want the patient to reach his rich and meaningful life, to live a happy life still, even though the pain exists. Then we have to fix some beliefs or core beliefs that the patient might have. Things like that pain is inevitable and suffering is optional. We have to make the patient believe that pain is inevitable. You gotta feel the pain. If you have to feel the pain, that it is what it is. But you don't have to suffer. You could have a chronic pain but still not being disabled. There is difference between disability definition and chronic pain definition. You could have that chronic pain, chronic low back pain, but still not feel disabled. You still have goals and things to reach in life, and you do that effectively even though you have that pain. So the pain is not limiting you here, and that's what we work on. Then to manage the emotional distress and negative thoughts, most patients with chronic pain will develop by time or at any time of their life some emotional distress, some anxiety, some social isolation, maybe depression if it's a severe case. Not to mention that some patients already have mental disorders. The patient could be schizophrenic. The patient could have PT, post-traumatic stress disorder. That makes it even more challenging. But we need to educate the patient about the pain, the nature of the pain. Okay, not in details, but the patient need to know what is he dealing with. So we gotta tell him about how that pain, how he perceived the pain, how that pain happens. How his brain perceive the pain, and the way it tries to control it, what things can make it worse, and what things can relieve it. Then, and how to have control over that pain. That's the most important part of it. Then, to improve the functioning, we don't want the patient to avoid physical activities, because that's probably gonna worsen the pain, gonna make them feel more disabled. So instead, we need a patient to still do their physical activities, not the aggravating ones. Just even if it was light physical activity, things like yoga, walking, that would be enough, and better than just staying on their couch and home. Then we build and maintain effective coping skills. And as I said, building and maintaining effective coping skills are two different things. So it could be easy to build effective coping skills, but maintaining it is much harder. Building coping skills that enable the patient to live with that pain and control that pain is one of the main goals. Things like relaxation techniques that we will talk about later, guided imagery, to fix their negative automatic thoughts, all of that. But then maintaining it, over a long time, even after discharge, the patient must continue to use these effective coping skills. Then we want the patient to be open, active, and aware. We need a patient to be open to these ideas that the pain is here, it's here. It's not gonna. It might not be better. It might not be worse, but it's just here, and that's what you have to deal with. You have to be open to the idea that the pain might not get better, and you have to live your life still. And we want them to be active, and motivated to participate in the treatment therapeutic programs still. We need that patient to stick to the program, to prevent the dropouts, to still do their homework, exercise, to be motivated to do that, skills, coping skills, and to be aware patient, to be aware of the process, to be aware of how they perceive the pain, to be aware of their cognitive thoughts, automatic thoughts that they have, of their core beliefs. Because if they are aware to their core beliefs and negative thoughts, that will make it, they spot these negative thoughts, it will make it much easier to deal with it. Then we're going to talk about why do we use this approach. We mainly developed that approach because of failure of biomedical model and passive treatments, things like electrotherapy, chiropractic, massage therapy, and such things to manage some cases. Even some surgeries, the patient would continue to have that pain even though they did the surgery, even though the pathology is no longer here. Things like examples like herpes zoster, for example, they would still have that pain even though the disease, just ended. To manage some cases of chronic pain, yeah. So the biomedical model was a bit limited because of these some patients that still have the pain even though the pathology is no longer here. They still have the pain, great intensity of the pain, even though the tissue damage is very little. So we needed something to give us broad understanding of why they still feel that pain. Then that's leading to worsening of patients' symptoms and developing depression and anxiety. And we don't want to put the patient in this loop, which will make them more disabled and more anxious, depressed, and nervous. Um, So they start overdosing in medications, narcotics, deconditioning, isolating from the society, and doing these small adaptive coping skills just because they don't understand what they are dealing with. So the aim is not to train physiotherapists to be psychotherapists. That's not the aim at all. What we want is to provide them with selected set of skills that were deemed to fall within the range of usual practice of the profession. So it helps us to get a better patient-therapist relationship, to reduce the dropouts along the treatment, also establishing effective coping skills and communication skills so that the patient feel heard and motivated to adhere to the treatment program. Areas of training. We need to train our therapists to recognize the barriers to engagement of pain activity. What's limiting that patient from doing that certain activity other than pain? Okay. Um, and that would need us to figure out their core beliefs. The patient might be like, oh, I'm not doing this because it's hurting me. They may be having that catastrophizing or kinesiophobia, you know. Then we need to do pain education and reconceptualization of pain. We need our therapists to understand the nature of pain so they could deal with it, so they could understand it and make it easy for the patient to understand it too. We need to build psychological flexibility. We will train to know how to build psychological flexibility for that patient. So the patient will be able to accept the pain. That's what actually of the acceptance and commitment therapy, to accept the pain, to deal with it, and still not feel disabled. Actually, also building active coping skills and relaxation techniques, as I said before, things like deep breathing, things like imagery, guided imagery, and such things actually are so helpful to manage that stress and pain flare-ups. Building internal locus of control and overcoming the resistance to incorporate in activities and in treatment program. Some patients may have this external locus of control when they feel that the pain happened because of maybe punishment, because of nothing that they can't control, or that they can't control that pain. It's just here. It will continue to be here like forever, and it might get worse and might get really bad, you know. All these thoughts that they may have. Um, is a kind of external locus of control. The internal locus of control that we want to build is to establish that no, you are able to control that pain, and there are ways, effective coping skills, active, that we can manage that pain with, and you can continue to live your life even though you have that pain. And then we address the kinesiophobia that, as I said before, things like kinesiophobia, catastrophizing, all these things will make the patient feel even more disabled. And hence, you know, worsening their mental health. And faulty core beliefs. The patient might have faulty core beliefs. Things like the pain. I've tried everything, and the pain is always here. It will never get better. Things like that. These are faulty core beliefs that we need to fix. Okay, that's all for today. Um, I'll do more lectures about the pain and the neurophysiology of the pain in the next few lectures. That's just an introduction to the program or the approach. We'll be talking about it more later. Thank you.